any recommendations that the Stevens Group has brought forward, or any recommendations members of the task force would like to see the task force consider. Also, we will be having recommendations brought forward with the path forward with regard to managed care. So 7 March will be a busy meeting. 29 March, it is my hope that any recommendations that are approved or adopted can by that point be converted into legislation that the task force would be able to review and prepare for any implementation as we get to that point. One final point I'd like to make is there's been some discussion about RFPs, and I just want to make clear for the audience and for the members of the task force, our role is really just an advisory and recommendation role. We are not going to be an entity that actually issues RFPs, approves RFPs. The only RFP that comes before us is for consultants and tools that we need to make recommendations. But as far as actual changing of rules, issuing of contracts, approving legislation, that will go through the normal legislative process. So that's kind of where we are with regard. Things are beginning to get to a point where it's time to issue some final guidance, and we'll be doing that in the next 3 meetings. So that's kind of what I see as laid forward here. Some comments, recognized for comments.
Thank you, Senator. And as Senator Hendrick just laid out, the 2 main things that we're focused on, savings from the traditional Medicaid program and what follows when the private option ends. There are policy decisions, but one of the things that the Stevens Group, the governor, and others are going to be doing as they present this is linking that directly to the dollars, because they're not just policy decisions. They have massive impacts on the Arkansas budget and taxes over the next 5 years. And so we'll have both of those pieces. I'm going to continue to emphasize that. I know that's kind of like the dumb guy at the party that keeps bringing up that nasty fact, but if we don't consider our policy decisions in the context of the financial implications to the budget, we can live in a fantasy land that a decision on policy really is easier to make than it actually is when you consider the ramifications financially. So if you've got thoughts or people who want to look at numbers and data so that when the consultant shares data, we can be aligned on it, please let me know that. I want to have us aligned on the data so we can agree on the facts as we're making those decisions. Thank you.
Okay, next item on the agenda is item C, which is to adopt the minutes from the December 15, 16, 17 meetings. They're exhibits C1, C2, and C3. And let me just say for the benefit of those out there, all the exhibits that we'll be looking at are posted online. So I have a motion to adopt the minutes from those meetings. So let's second by President Farrar. All in favor say aye. Aye. Minutes are adopted. Okay, item D on the agenda is update on activities and accomplishment. We've got a long list of things here that Stephen Group's going to go through. So John, Richard, Stephen, and Roy, y'all are recognized to start with, again, item D on the agenda there. I'm going to do a presentation for us members, which is in your packet, item D. You're recognized.
Thank you, Mr. Chair. Just so that the members know what's before you, there is a document that we have, a Word document that's status report update that has a number of these items in a little more detail that are in PowerPoint today. And I'm going to go through some of the follow-up items on the tasks that we've been assigned since the last meeting, and we'll be happy to answer any questions. The agenda today with item D is as follows. First, we're going to outline for you our guiding principles for the PCMH, Health Home, managed fee-for-service model. We're going to then talk about some of the high-cost PCMH and Diamond Care recommendations in particular that we're looking at for the February meeting. And we want to the purpose is really to make sure we get all of your input and thoughts before we get to the next level. We've been meeting with a lot of providers and a lot of individuals in the community, and we want to make sure we're ready when we come in February with the model and the savings estimates. We're going to then go over baseline cost savings estimates to make sure we're all on the same page so that nothing, there's no surprises come February. When the governor mentioned $835 million and whether or not that was directly connected to page such and such in our recommendations, I just want to make sure everyone's clear on what we're looking at. And then we can take any questions and thoughts on your part so that we can get everything under consideration. Then pharmacy recommendations are already in progress. I think we've said from day one that we won't really want to hope, we hope that DHS moves forward and doesn't wait for task force response on things, because savings can be made now in certain areas that we saw and observed, and they're making progress in pharmacy, and we wanted to update you on that. Then dental claims history, we really didn't get a chance to update you on claims. I thought as you move into the managed care world of dental and your decision you made, I think you want to start seeing some of those claims, to look at what it is, what they are, and then also ideas on the RFP process, just to give the department some thoughts as well, unless you have, if you have any questions. Then Senator Hendrick had a question on integrating best services systems. We've done a lot of review in other states. There's some detailed information in the status report, and we're going to just briefly go over it in the PowerPoint slide. There's some update that came out of CMS on a 1332 waiver, and there's states that have enacted legislation that we want to make sure you're aware of. And also Michigan just had its expansion waiver updated or approved, and we want to go through some of those details for you. So I'll start with the guiding principles. So this really captures the guiding principles of the PCMH health home non-capitated full risk model for high cost populations. What that means basically, in a lot of your eyes, not managed care. But it really is managed care because it's a managed fee for service. And so that's a coordination of the benefits, and it's the coordination of the benefits by an entity or entities. We're looking at a number of states, we're talking to a number of people, so we still haven't fleshed out exactly what it will actually look like in terms of our recommendation, but I can tell you the guiding principles are as follows. The savings estimates, and if there's any question on any one of these, I can just stop at the chair's discretion. The savings estimates will be based on an allocation methodology that considers efficiency, savings, and quality across all populations and services. And that's in the traditional Medicaid program. Savings target will be applied to the entire traditional Medicaid program. The target will exceed $835 million over 5 years. And that's because we want to make sure we meet the governor's numbers, and that what we recommend to you actually will come in and meet with good probability $835 million. The savings target will include all funds, not including additional revenue from premium taxes. I think that's important. It will be a straight general fund and federal participation on Medicaid. Savings targets will also, the estimates will be independently verified. We will make sure that what that means is we're going to have backup for any savings estimates we give you on a prior best practice or something we can find in another state or states that has actually worked. We're going to try our best to stay away from anything that is new, hasn't shown some experience or success. The model will assume new management structure to administer long-term care, behavioral health, developmentally disabled, and other high-cost populations. We will take into consideration what plans have been given to the governor. As he suggested, he wanted us to look at it, and we will. And that could be absorbed within those management entity. The model will include aspects of diamond care, such as linking the patient-centered medical home to medical, pharmacy, and waiver services for high-cost populations. I think the last point, waiver services, is really important because that's one area that has not been connected in the past. We will be looking at independent assessment, plan of care, claims payment, utilization management, high-cost case management, call center services, member outreach, provider relations, grievances and appeals, quality improvement, and robust technology. This means that, if I just go back, there's a lot of these functions that managed care companies also do. But this means that the management entity or entities that are going to be coordinating those benefits are going to be handling those at a management fee. It could be an administrative service management fee, or it could be a per member per month cap fee, but it's going to be some management fee. But it's not going to be a full capitated risk like a managed care company. And it's important that we outline those issues because Your assessments today, for example, in Diamond Care, the recommendation was to have independent assessments. We thought that was one of the very important part of our own recommendations. So some of these issues are already things that are being done by contractors today. And I want you all to know that in our recommendations, when this goes live, those contractors are either gonna no longer be doing what they're doing, and there's gonna be the management entity or entities that's gonna either absorb those activities, or, in our recommendation, obviously, or, those activities may be done more efficiently by the entity on its own, or its own. The model may include, because we still haven't figured out how this would work and whether the department should be doing this or the entity, network development, for provider credentialing, and in its own aspect of fraud, waste, and abuse, which you're already doing here with OMIG in your department. And then the question becomes, what type of enhancement is used by that entity? The model is going to assume state plan and waiver changes. It may include tier payments, changes to level of care, rebalancing, and changes to promote least restrictive settings. The model will recommend a global Section 1115 waiver, which is part of Diamond Care recommendation and our recommendation as well. And I think that's very important for maximum flexibility from the federal government, and also to maybe get some enhanced federal financial participation if there are certain benchmarks that are met that are, I would say, consistent with your overall vision in what you're trying to accomplish. The model will also assume that we talked about the contracts for similar services will either cease to exist on the go live date and will be absorbed within this single management entity or entities. The model may include additional prevention-related services. And the entity or entity is going to have a direct link with the primary care medical home environment and your primary care physicians who are in your robust, low-cost network currently today. The recommended administrative management entity will share in both savings and losses. Losses including being unable to meet contracted quality outcomes and agreed upon savings estimate. I'm going to highlight that. Share in losses as well. The only way we're going to be able to certify that you can meet the savings target that the government wants is you're going to have some real strict performance measures and basis in your contracts.
Hey, John, I see you've got management entities several times in these principles. Explain to me the structure that you have in mind for the management entity.
Well, if we go back to these functions here in this slide, you will have, we met with, I know that there was a provider that was recommended for us to meet with that handles a lot of these activities today. You have, you could have a provider, I don't want to name any provider, but you have insurance companies that also could do a managed fee for service. It might mean that the PMPM is $50 a month, and they're
I
just
guess
doing
what I'm asking,
covering.
are we envisioning a situation here where we are contracting out to a third-party management company entity rather than having state employees or a state agency oversee this?
Oh, that's absolutely correct. There's no, in our opinion, to independently verify those types of savings, the state agency is going to need this type of facility.
So it's really the terms of the contract with regard to what we're asking of a managed care entity is just different.
Correct.
Okay.
Correct. And then the risk is different too, Senator. That's really important. You're not talking about a full risk. You're talking about shared risk. And you're talking about something that either has the likes of administrative service organization in which, and I don't want to jump to the slide, but Richard's going to talk about some of the actual models as we go further. And I think that will help. And it could, when I say entity or entities, plural, you're going to have a number of issues. For example, in one state, you have one vendor that does independent assessments, plan of care, and is the managed fee for service entity for the development disability waiver. One entity. You have one entity that's doing it for the behavioral health waiver. Maybe we'll recommend that the entity do it across the board, but that there be more than, if you're going to do it across the board, CMS is probably going to require that you have competition in more than one entity. So those are mechanics that we'll figure out down the road. The management entity will be responsible for receiving a portion of savings, and some portion of the risk will be shared by providers. And I say that because I do recognize that, Director Seelig mentioned a few meetings back, that providers sharing risk, he has a concern about. And, you know, we have a concern. I'm being honest with you, that's a concern. But we're gonna try to make sure there's a recommendation that, is reasonable. But again, there's gonna have to be some risk here if you really want to make sure that we can certify and feel comfortable with those savings targets. The management entity will
We
include.
got a question, if you don't mind. Senator Cooper, you're right to ask her a question.
Thank you, Mr. Chair. To that point that you just mentioned, in some of the studies that I've read about that has to do with other states, there seems to be a sort of a gap between studies that government entities do and academics do. There's not full agreement along that line, and can you speak to that and how we can feel comfortable in whatever data that you are looking at and presenting, that we have confidence in whatever that might be, because there's a gap out there between some of these studies?
There's always going to be a gap there. And maybe I'll make you feel a little more comfortable. For example, I'll give you an example. In our recommendation, the state of Texas, when we go to the states and ask about, let's say, managed care, what are the savings? The state gives us a baseline savings. The state tells us what they've accomplished. The state may not tell us everything that the providers in the community are saying. And then you want to have an independent study. In Texas, Texas was promoting the $7 billion that they saved in managed care over the past few years. I spoke directly to the commissioner and to the director, the state commissioner, and he was mentioning how managed care was the best thing that could ever happen to the Medicaid program. And he shared with me all of the savings estimates. And then Stephen and a few others on our team looked to find independent verification. And so we found the Milliman report. Milliman is an academic type actuary company, and independent, and Milliman certified, in fact, that those savings did occur. So yes, to answer your question, Senator, we will do the best we can. But I am going to probably, and I want to make this clear, because right now from the savings estimates that we're looking at, we are going to the state leaders. There aren't a lot of academic journals or articles out there that will tell us, for example, Connecticut. You know, Connecticut's an ASO model. Left managed care, went to ASO. I called Connecticut. I tried to get information from their Bureau of Legislative Research, has some documentation on the ASO. Would you say that's independent? You know, but then that doesn't tell me what the savings were. And then I read the newspaper article and I see where the governor is asking for multi-millions of dollars more in Medicaid because the Medicaid program spending is going up beyond what they had thought. So, you know, your question is a very difficult question to answer. I just want to make sure we'll do our best. But I rely on state leaders to give us data that we, as a team, can then try to look at. But it's going to be hard to find everywhere where we get independent academic research.
Thank you. Thank you, Mr. Chair.
And again, I think the level of risk is going to be so important in the end because we want to make sure those savings are met, and also that there's enhanced quality to the program. And that's why the management entity has to have credentials and make sure that they're qualified to meet, and that stuff you spell out in your RFP, quality standards.
Are there any states right now that have implemented a model like this?
Yes, we're going to go through that. Yeah, Richard's going to talk about that. Again, when I say a model like this, we're not finding a state out there that has actually implemented a model where they put them all together with one entity or entities managing those all high cost, cross high costs. So our recommendation may be different entities within, but part of our team that sits back and says, you know what, we think the least amount of entities that you have to manage in DHS is much better. So we're going back and forth on that portion right now. The management entity will include aspects of management of complex Medicaid children not currently in PCMH. I want to make sure I highlight this, and I know that, you know, we've talked a lot about the PCMH program here in Arkansas. When we started to meet with some of the folks, we didn't realize that there are certain exemptions put into the PCMH program today, that there are some populations that should be in PCMH, should be managed, but aren't. are exempted because the costs are too high, and someone at DHS has decided with the providers that we're gonna set the cap at a certain level. We're gonna take those populations, and those populations are gonna be part of this management. So that will be more coordinated care, and we think that's an opportunity for savings for you. We're also gonna be recommending centers of excellence. And what we mean by that, or a center of excellence, is because we have found in our meetings recently too, that you have some areas in the state where if you have more consolidation of excellent outpatient, inpatient focus on a primary medical area rather than the whole system, you might be able to achieve savings there. So we're going to have a recommendation on that. The savings will take into consideration current efficiency efforts at DHS. So we're meeting with them now, and we'll continue to. And you're going to hear about pharmacy today. We're going to meet with the OMIG, and we're going to be talking about program integrity, because I want to know what their own recommendations are for enhancing program integrity going further out those 5 years. So are the recoveries going to be higher? Is it going to be greater cost avoidance? And we're going to try to get you anything that we feel the department is going to be working on that we would certify as credit. And then I do want to cite necessary legislative and rule changes to be accepted by the legislature. That's the last point here. We're going to issue recommendations in February, and we're going to have a few things that we think need to be done legislatively or rules. And our group will certify that we think with reasonable certainty you can achieve these savings if these rule changes are made. Now, if these rule changes get hung up because of political issues or something else, then I just want you all to know that that's something that, is going to impact every dollar that we recommend. And we're not going to recommend a lot of legislative and policy changes. There's going to be some that will have to happen, but there are some that's already come to fruition and we think that we need definitely to recommend in order to meet those savings targets. The estimates will include enhanced public integrity, or actually program integrity. I should have said program, I say public, but it's program. Savings estimates will be net of administrative expenses. That's going to be something we're going to work on with the department. There may be instances where the department's going to need additional resources, and we're going to need to make sure we take that into consideration. There are going to be other areas where, you're now going to have a management entity covering something that the department was covering in the past, then there should be an elimination of that position or positions. It could be repurposing even, but there should be some reduction in cost there. So we're going to take all that into consideration. The timeline for the savings estimates will ensure readiness. We said in our recommendation the managed care timeline was somewhere around 18 months to 2 years. This is not much different, but we'll do our best. And the one thing you need to make sure you take into consideration is your EEF system changes may impact some of the timelines as well. So it's good for you to always be focused on those issues.
Okay, we got a question. Representative Ferrari recognized.
Thank you, Chair. John, you asked, you keep saying, DHS may have to have more to help do this. Are you taking that into consideration of your changing of the DHS, pulling Medicaid out and restructuring the Medicaid system? I remember back when this first started, you had a whole new flow chart of the Medicaid system. Our DHS was designed. Are you still doing that?
I guess how I would answer that is we recommended a certain reorganization, but that's something that is within the purview of the executive. What we're going to give you is within the structure that we see today. Because we don't know if those reorganization changes are going to be made or not.
Okay, so you're not going to come out and give us a restructure of DHS to meet your goal? No?
No, it would have to be, these are the resources they're going to need to manage this particular entity or entities effectively. Wherever they are within the department is something that, we've already stated what we think should happen.
Right. Could you,
I'm trying to get at what the question really is driving us and want us to do.
well, I'm guessing, you're keep saying that if DHS can do this and this, and I just remember back, like I said, a month or so ago, you come out with a whole new flow chart of DHS. Are you designing this program toward that, or are you designing it toward the current
I guess I would answer that by saying we'll design it so that it can be flexible to match both, whether it's today, stays the same, or whether it's more integrated, like we had suggested.
Okay, I guess that's my next question. Are you going to suggest that we restructure DHS to something near what you suggested?
Yeah, I mean, we can go back over our recommendations. I think we've already suggested that. We can do it again.
Okay.
I mean, there needs to be integration of behavioral health, ED, and long-term care on the policy side. I think if you do that, it's going to really enhance the ability to achieve the savings.
I'd like to see that.
Okay. And then savings may be derived from additional DHS initiatives we talked about. And then we believe the model will recommend some, we've said this in our recommendations, some savings to be used towards the developmentally disabled waitlist. We're just going to remind this task force that we think that has to be an issue looked at, and it's obviously up to all of them. But if you're going to achieve savings, I think it's important that some of those savings go back into the program. But again, that's going to be a policy. Does anyone have any questions or thoughts to add to those guiding principles?
So these are what you're going to use to formulate your presentation for the next meeting?
17, correct. And then I'm going to hand it over to Richard, who's started to do some research in other states. And just to give you an idea of what we're finding right now, and again, this is all very fluid, but you know, we're definitely going to have our plan ready for you by the 7th.
Thank you, John. Members of the task force. As John said earlier, the guiding principles in the organizational construction of a single entity or multiple entities doing the same comprehensive approach in different areas of the state has not been done under managed fee-for-service. So I'm briefly going to talk about the history of payment in Medicaid in real big blocks. As you all know, the Medicaid program was started fee-for-service nationwide. As states were capable, 60s, 70s, good part of the 70s, of handling the annual increases, which were substantial in relationship to the total state revenue, fee-for-service prevailed. States were able to suck it up, and they were able to pay for education, roads, etc. When the 80s started hitting and Medicaid started getting really big, several states were having problems. Education was starting to get crowded out, roads were getting crowded out, so they started looking for new payment methods. Just about the very first payment method that I recollect that came in was managed fee-for-service in behavioral health with a company named Merck. They started, I believe, in Iowa, and it was a disaster. There were lawsuits, and things worked their way out. Nevertheless, as that model was going forward in some states, just like we're talking here, every state's different, managed care and capitated levels started becoming important to several states. The states implemented full board integrated managed care, which we discussed in the final report. So as the last 8 or so years since the recession, I would say almost financial depression, hit America in 2007, 2008, many states have been moved into managed care on an integrated basis, and we've discussed that in our final report. So I want to put that context in on what we're finding today in what's called managed fee-for-service models, and this is what we found. Behavioral health and DD, to some extent, have been care management collaboratives with administrative service organization. This means there's a collaborative of providers that work with an ASO, we state contract, to do independent assessment. Aging, we've seen integrated waivers and global waivers that avoid duplication, benefit limits, caps, and tiers of services on. We have not found a managed fee-for-service model in a Medicaid program for long-term care services. It's out there, we sure would like to know, and I'd be embarrassed if we didn't find it, but we didn't find it. We also researched state agencies and vendors that we spoke about that John mentioned. We looked at market research from the health insurance perspective, and what we found would be the next steps for the February meeting that John discussed. There are 7 states right now, there may be 8, shifting from service ASOs, primarily in behavioral health, to to some form of regional care organizations at risk or full board managed care. Alabama is moving their whole fee-for-service to 11 regional care organizations at risk. Colorado has an at-risk system of their care coordination collaboratives, which are also dual eligibles. They're integrating that into a risk construction for behavioral health, which was a carve-out out of that model 2 years ago. Iowa, as you know, is integrating everything under a integrated managed care. They're supposed to go live March 16th. They had a behavioral health administrative services organization service model. Nebraska is moving behavioral health into risk integrated care, integrated managed care in 2017. New York's mental health system, they have full board managed care and just about everything else. Mental health's always been on the outside looking in. They're now moving, the Cuomo administration is moving fee-for-service, which has been what the big fight has been about in behavioral health in New York over the years. They have a behavioral health ASO, but they're moving to at-risk specialty plans for the serious and persistently mentally ill adults through their managed care organization. It's somewhat complex, but they're moving basically into full board managed care for behavioral health. And Washington's moving behavioral health organizations, which include 1915D at-risk capitated contracts into their full board integrated managed care, and the RFPs I believe are going to be out soon from 2017 to 2019. Oklahoma, I just think in the last week, has made some move towards integrated managed care. So the trend in terms of managed fee-for-service or at fee-for-service or capitated at-risk managed care is towards at-risk managed care on a capitated basis. Behavioral health has the richest ongoing history in administrative service organizations and fee-for-service. Arkansas, as you know, has what it has now. We've been talking about. Arizona has regional behavioral health authorities. They are capitated and at risk, but it is a carve-out. So that's why we put Arizona there. Connecticut, as you know, has local mental health authorities. They're not through the ASO model per se. In Connecticut, they're basically their legacy community mental health centers that are paid fee-for-service to the state mental health authority. The District of Columbia is fee-for-service. You can go down to Hawaii's. They're all pretty similar in the behavioral health side. Montana does their behavioral health through PCCM model. As you know, that state is extraordinarily rural and has pretty good support. And the only kind of access that's available really is through PCCM, but most of Montana has been out there. New Jersey is still fee-for-service, although this has been under study for going into managed care for the last several years. North Dakota is PCMH, South Dakota is PCMH. In Pennsylvania, they've got regional behavioral health authorities. There's 2 counties that are capitated and at risk. There's some attention in Pennsylvania to changing this model, however, there's a local government involvement, so we'll have to see how that ends up. Utah also capitates behavioral health provider organizations. They're at risk. Vermont has a state-run agency. They're really not analogous to any other state in the union. All this was set up in relationship to the goal of the single-payer system with Governor Shumlin disavowed in the past year because of the expense that's been generated in Vermont since they started moving to a single-pay system. The actual rate of medical inflation is much higher than it was when they were paying fee-for-service. So in summary, you got 23 states in D.C. in some form of fee-for-service and ASO-related delivery models for behavioral health. Some have some risk. There are 28 states that are in or moving full risk managed care to behavioral health. And that behavioral health set of services that I'm specifically targeting is a rehabilitation option. Clinic services, for the most part, in behavioral health are in states that have managed care or in managed care, integrated managed care.
Before you leave that summary, is there any data to say on a cost per person, per member, whether the 23 that have it versus the 28 that, or the 28 that has moved that way to the 23 that is not? Is it working on a cost basis?
That's an excellent question, and as John said, we are in the throes of a deep dive on trying to find savings, whether it's fee-for-service or a capitated model that's an ASO model. And that's one of the reasons why we've been in touch with the vendors that are actually doing this in the states that have them, and we expect to have that in our February report.
Okay. Senator Sanders, you're recognized.
Thank you, Mr. Chair. In addition to the senator's question, chair's question about the savings piece, I would be also interested in sort of the construct of the benefit design and how they go about building that, what are they using as their model. Some of them just using sort of the medical necessity as the baseline, or they're using some sort of structured episode of care, are they using evidence-based model? What's the construct look like? And then if you can, you may not be able to get there in terms of sort of any goals that they set out in terms of achievable goals when they of their programs, and are they meeting those goals, or goals, are they achieving those goals? And I'd be really curious as just looking at the benefit design.
Thank you, Senator. Benefit design in behavioral health has been in a state of change over the last 10 or 12 years. It's always been in a state of change, but over the last 10 or 12 years, as evidence-based practices have become known, particularly illness management and recovery. Illness management and recovery is a comprehensive integration of services that would be targeted towards adults with serious and persistent mental illness, who would generally form the nucleus of what you might consider your Olmstead population, that they have history of hospitalization, often in the state hospital. Repeat hospitalizations are generally indigent and may be transient to some degree in terms of their stability of housing, or in fact be homeless. And then you've got the aura of people outside of the Olmstead circle, if you will, that are at risk or may go in and out of that inner circle in terms of the level of their disease and their ability to manage it. So illness management recovery has been adopted by, I think, at least 15 or 16 states as a Medicaid benefit. That benefit actually was developed at Evidence-Based Practice Department Psychiatric Research Center. So that's one process. In the children's benefit that involves a level of rehabilitation option benefit, there's a plethora of evidence-based practices that are being integrated across the country. There are at least 21 states that I know of that have integrated some form of evidence-based practice for children with serious and emotional disturbance. And those are basically multi-systemic family therapy and multi-dimensional foster care, which we provide for a therapeutic-based model for foster care residential placements. And that benefit has also been adjusted into non-foster care settings for children that may or may not live with their families. There's a plethora of research in outpatient therapy, in cognitive behavioral therapy. There's manifestations of cognitive behavioral therapy and a therapy that actually was researched in Texas and is now an evidence-based practice called dialectical behavioral therapy, DBT. Lots of these states, Washington being one of them, they're in the benefit package, and the providers have to provide some measure of fidelity to these benefits. There's the Administrative Services Organizations in some states will be the entity that will deal with fidelity questions. In other states, it will be the state. In other states, it's the managed care entity, because some of these evidence-based practices, you might suspect, are in full integrated managed care. So I don't have a scorecard on what states benefits, but the point of the matter is that the states that have moved their mental health systems ahead have integrated evidence-based practices into their mental health benefit for people with serious and persistent mental illness, and that's in kids. We recommended that in our final report. And if you go down that road, and we'll get the recommendations later, it takes several years to bring this up. This is not something you can do overnight. You need to work with where your provider community is in terms of credentialing, and not throw out the baby with the bathwater, but just have a goal and stick to it.
Yeah, I think part of the struggle that we have, what we're trying to do is some sort of true comparison. And a lot of times, what we started off this process with this one Medicaid program, this one Medicaid program, they're all different. But to the extent that we can sort of equalize and try to get some sort of comparison as to maybe something we offer that other states don't offer, or vice versa. Or and then I know you guys have worked in a lot of other states, so we're all treated this because of New Hampshire's persistent drug problem and the problem with opioids. So, the extenuating circumstances and the external factors that are sort of driving, some of the spend too. I mean, any type of, sort of rounding out of the knowledge and for comparison's sake, I think will be beneficial to us.
Appreciate that.
You can spend, and you can write a book on it, but I mean, I think it would, maybe finding some things that we could, that would offer up more of a straight up comparison would be beneficial.
Appreciate that, and I think perhaps that can be addressed when you look at the recommendations that we make a little bit later on in the report on the data analysis of the in-school programs.
Okay, Senator Elliott, you have to ask a question.
Thank you, Mr. Chair. I don't mean for the prelude to the premise of my question to be connected to all you just talked about necessarily, but what I'm wondering in the whole illness management continuum, where does hospice care fit in this whole discussion, or is that going to fit someplace else?
Hospice care generally is a medical service and would be dealt with under general medical services. And I believe in the vision that John pointed out in terms of the guiding principles would be included in a comprehensive approach towards a managed fee-for-service model that we're developing and will report on in February. So hospice would be covered there to the extent that it's in the state benefits today.
Okay, so we could look for that in this broad parameter that you gave us in these principles, and it'd be up to us to make a determination about where it fits in. That would be the proper place, but it would be up to the task force to decide.
I'm sorry, I don't really quite understand.
Well, if it's encompassed in some way in the broad principle that you just laid out, I'm assuming in the broad principle, so because you're not going to tell us exactly what to do, you're going to just make some recommendations. It would be up to the legislature to determine exactly where it might fit and how we want to handle it.
Yes, and if I understand your question, it was same for behavioral health, same for the nursing home, same for the developmental disabilities waiver. You decide what you want and what kind of model.
And I would say that where we recommend any benefit redesign, we'll state that specific.
Okay.
So if we don't state a hospice benefit redesign, you can assume it's going to stay within the same benefit structure we have today.
Okay, that's helpful, very much. Thank you. Thanks, Mr. Chair.
Okay, moving to
We got one more question here. Senator Cooper, you're recognized.
Thank you, Mr. Chair. One bleed over component is in the cost of the state budget is prison costs and mental health costs and Medicaid. And do you have any data? If you affect one, you affect both. And you can lower the cost of mental illness, you affect not only medical issues, but also prison issues. So is there anything there that, that'd be a double bang for the buck if we could affect both those components? Is there any way that we know, or any data from other states, that something that would affect that as it leads over to prison populations?
That's an excellent point. We haven't really researched specific data on cost offsets, and I think in terms of states being able to model that, it almost sounds like an academic research project. However, states that have moved their mental health benefit ahead, either through ASO, I know in Arizona and Maricopa County, and in the state of Washington, there's direct connections on people who are being discharged from state prisons and referrals immediately for not only Medicaid eligibility, but if they have a mental health diagnosis in the prison system or history, they get referred to treatment immediately, pre-discharge. And that connection is made through either the managed care entity, as it is in, will be in Washington, or through the administrative services entity, as it was in Arizona, and probably still is. The contractor that I was aware of is no longer that contractor, but I believe there are models like that out there. And that can be written into your benefit. It is part of the entire package of how you want to target those resources.
I've seen some other research on that, and I suspect that there was something out there that could maybe pull that together as how it affects both. And I think that has possibilities of immediate referral before some event takes place.
I appreciate that,
Thank you.
and we can take a look. One of the problems that I think we're gonna find is the research on these cost offsets are not longitudinal.
Right.
Like the budget cycles, because that's the way states work with budget cycles, but we can definitely take a look.
Thank you, Mr. Chair.
Okay, in the area of developmental disabilities, for the most part, most of the states are still fee-for-service through their legacy IDD systems. Tennessee, Arizona, Vermont, Michigan, Kansas, recently, Louisiana recently, New Hampshire, very recently, and Texas have moved either their medical services and waivers into managed care or medical services. Texas is going to move their waivers in 2021.
What's IDD?
Intellectual and developmental disabilities. Excuse me, sir. West Virginia was the only state that we could find a contracted out administrative services only developmental disabilities project. We know something about it. It was sought by the state during litigation into their developmental disability system and extremely high cost. That entity is still there. And they do objective third-party reviews. They do the individual assessments. They use national standards for their instruments. The primary one is SIS, which this state has looked at and had support from the provider community, as I understood it. They conduct face-to-face assessments as well as use medical records. They do prior services authorization. They provide medical necessity determination off of their state's rule. They create authorization in the MMIS fiscal system. They do statistical budgeting for the state for both the consumer. They call it an individual budget, and we think that's an excellent practice. It ensures budget adherence in the aggregate and on the individual case basis. They also do provide oversight to make sure, in operational terms, that if they've approved 10 units of day services during a week, that those 10 services have been delivered, if not why, and they also find out if 15 service units were delivered. And then they'll make adjustments and talk with the provider and go through an administrative process to adjust that. And if it's not appropriate, then they'll have to be paybacks. They do all that monitoring. They do billing and claims accuracy. We want to make that clear. They do the claims in that state. That's one of our guiding principles in the model. They do quality management, as you can see, and most importantly, from the participant experience and family survey, as well as over the consumer-directed services. In aging, we have not found a managed fee-for-service program.
So the next set of slides is now we're moving into financial projections. So this is important for you all to pay attention to, because really, when the governor came in with savings, we want to make it clear so you know where we're coming from in terms of our own recommendations as we come into February. And Stephen will answer any questions, but I'll basically take you through the slides. It's not that difficult to look at these. And I want to make sure, first of all, clarify a few things. The 2015 the actuals are in for fiscal year. So we met with the department, got some information from them. Stephen had gone through the analysis. The financial actuals at 4.8 billion basically for traditional Medicaid. It's not going to exactly match the 5.1, I think it is, in our recommendations in our report. Because if you remember, the medically frail are within that traditional Medicaid program. They're newly eligible under expansion, but they're actually put into traditional Medicaid. And it's a higher level of match. So what we've done for this analysis, so when we're starting to target our savings for the actual traditional program, we wanted to make sure we come up with an actual baseline that we can start from, so that every member of the task force too can actually identify the baseline. And now when we look forward out 17 to 21 and future years, whatever savings in the models that you all approve, we want to make sure that they're going to be targeted from that baseline, that everybody's on the same page. So this is the actual baseline for the traditional program, not including medically frail. Okay, so that's 4.8 billion. The 5% annual growth factor that we used in our recommendation, because we already gave you the research from CMS and others that have projected a 5% growth over the next 5 to 10 years in Medicaid spending among states. It may be that you guys are higher or you're lower, but we're using that as our reasonable baseline for growth on the out years. Now, you just happen to have a 2% growth year. We talked about that in many meetings, and Director Seeley talked about it. We also had 8 to 10% a few years ago. And we don't know what's going to happen in the future. So this is, again, key estimate on the baseline. But I think 5% you can feel comfortable with.
Okay, John, let me just make sure I understand this, because I think this is important for all of us to get a good grasp on. So as we start talking about the $835 million in savings that we're trying to accomplish over 5 years, right now at a 5% growth rate, we're going to spend $29.7 billion. Your bottom number there, right?
Correct, all funds.
So if we are successful, then it would be $28.9 billion.
Correct?
So I mean, we're
We're
talking
gonna get to
about
that.
cutting $800 million out of almost $30 billion over the next 5 years.
Correct. Correct.
And I
Well,
guess-
what I wanted to make sure is that everybody's comfortable when I spoke to the governor's office to make sure that the $835 million was using our 5% baseline growth projection. And they confirmed that it was. So you're correct, Senator.
So again, and I guess the reason I think it's important for us to understand is the difference between 5% annual growth, which is our best guess, and 2% annual growth is what, $5 or $6 billion over that same period?
We're going to get to that right now. Yes,
Okay.
pretty substantial. And again, I think it should underscore the fact that the governor's not talking about, and we weren't talking, you're not talking about cuts. And I want everyone to understand that. You're not talking about cuts. Because you talk about cuts to the program, the actual cuts from the baseline, you're talking about spending less than what you spent the year before. Okay? So when you look at projections.
I guess the only thing I would add to that, John, the only way that a provider or the community might disagree with that point is if your increase is due to an increased number of people eligible, like the aging population, then you're going to have to service that people perhaps on less total dollars per person.
And I should rephrase, correct. I'm just talking from the global
Right.
aggregate budget standpoint. You're absolutely correct. There is going to be some impact here.
Yeah, okay.
Correct. And in some areas, it may be substantial, because maybe that's an area that we think is inefficient there. You know, we're going to have to look at that. If you look at the next slide here, 15, if you were to take the 4% growth, then you're talking about a total of $587.9 million in savings over that 5-year period from 17 to 21. If you go to the 3% growth, and the reason why we use 3% here, we were looking at your number for revenue that you get, tax revenue for the state, and I know it's around 2.6%. So if you were to keep the program at about the same level of the amount of money coming in on your tax revenue side, you're talking about much more than what the governor had requested on the $835 million. Under this scenario, you're talking about well over $1 billion.
Okay, we got a question, Representative Hammer, you're recognized.
Thank you, Mr. Chair. One thing I was wondering, John, on your 5% annual growth projection and on your 4% annual growth projection, what weight did you give to these numbers that could be assigned to the fact that by covering more people and doing all the things that we're proposing to do should actually lower the cost because we're going to have a healthier population? Did you give any consideration to that theory or to that idea?
These are just straight line growth projections here. These do not take into account any dynamic effects due to improving the health or utilization levels of the population.
So do you have any hard numbers from any other states that you've studied that would factor into part of our savings is going to be that we shouldn't be spending as much because if we reach our overall goal, which is to have a healthier population, we should have reduced cost, and how do we grab that number out of the air to be able to factor it into our decision?
As we look at, as we actually next month put the different pieces together and project the savings from different programs and programmatic changes, some of those types of savings will be brought to bear. One specific example is if you think about expanding the PCMH program to all providers and all patients, we can start to apply the actual savings that we recognize within those slices of the savings program that are currently active to the whole population.
So that will come next month's report?
Correct.
Okay, thank you, Mr. Chair.
Senator Bush, we got another question here. It's from our member that I welcomed earlier at the start of the meeting, Senator Bush, may you recognize.
Thank you, Mr. Chairman. And just real quick, and I flipped ahead to make sure that I wasn't going to ask a question that maybe you're going to cover in a little bit. It's one that just the couple of times I've had the question in the past is, you know, what we're looking at right here is the total spend, that's Fed and state dollars. And our biggest concern that I think we have on the immediate horizon is the change in the AFMAP percentage. And I guess what I would like to see at some point, and maybe it's out there, it's just is the breakout of those dollars. Number one, the Fed versus the state, and then also inside the programs, which are the 70-30 match or the equivalent, which are the 50-50 match, and that sort of thing. Because I think on the state level, when we're doing our budgeting, I mean, those are the savings that we're looking for first and foremost. I'm not saying that we don't want to reform the system to save everybody dollars, but on the front end, we have to be very mindful that the FMAP is our immediate concern in that change. Because we could lower these dollar amounts across the board, but as long as our FMAP is going, our actual state share, which matters when we're developing our budget, may be increasing, in excess of those savings, if that makes sense.
Yes, Senator, it's a great question. What we'll do in our February report is break out share, FMAP and state share, general fund, so you can see that. It's traditionally here we've looked at a 70-30 type mix, but you need to be mindful of that, because if that goes up, as you say, it has some significant impact.
So really what we should be looking at some point in the future is you have a column now that just has the Medicaid expenditures with an estimated 5% growth, and that's cumulative for everything, state and Fed dollars. You're going to do a projection on the FMAP rate changes.
Yes.
And then you're also going to have probably a side column to that that's going to break out that 5.3. So you're going to break it out Fed versus state, and you're also going to have, I guess, another column then that would break out what portion of that 5.3 is set up as a, in the 70-30 match, what percentages for administrative costs, 50-50 match, and that sort of thing. Because, for me, I think that's what we have to look at everything. And again, the state budget is what's critical to us.
Yes, we can do that. I just want you to know that the vast majority is the 70-30 split. The administrative costs at that 50% level you talk about is very minimal in the program. But we'll do that for you.
Well, and then, okay, and kind of following on those same lines, then we be breaking out care versus contract? I mean, we have a lot of contract expenses that's done, something that's been rehashed over and over again. I think we'd like to see some savings there, and in true state dollar savings, and so that'll be a different component also.
And again, it's a great question, because some of your contracts end on my S 910, some of them are 50-50. Very good question.
Okay, thank you.
And we will do our very best to get that. A number of I think Senator Ingram had been asking about the breakout. When we gave you originally in October, I believe, the breakout of each area, program costs, waiver program costs, and then also we use the term HALO to make sure you understand there's also medical costs that are used by that population. In the behavioral health side, for example, the direct program costs were somewhere in the $400+ million side. You'll see that later. But the HALO medical, there's a lot of psychiatric and hospital admission, was somewhere in the $400+ million side. So that program alone was about $1 billion. And we wanted to break it down program by program on the high cost population here, so that you can see, and we estimated HALO going forward. And this is an estimate. But then this gives you at least a good idea about each category, how much each of these high-cost areas spend in your budget. And we want to pay attention to this, because as we go forward with savings estimates, we said we're going to be allocating savings, but we're going to allocate the savings where we think, they can best meet the good quality and improving the program. And it may be that there'll be more on one area, less on another. But again, this might be an area that you may ask, what's the impact of development disability? And now you're going to at least get to see the baseline of how much is spent in that area. Okay? And then there's going to be other areas, program integrity. drug purchasing efficiencies, contract renegotiations. There might be, so we're gonna look at other areas that we feel can be, savings can be had, and I know pharmacy is gonna be one of them. So it's not all gonna be absorbed within this management entity structure. And I'm gonna turn it over to Rory, because Rory's gonna talk about pharmacy progress, because I think it's encouraging to see that some of these pharmacy recommendations that we had are actually starting to be, or you actually adopted too in your final recommendations, are being met by the department now. Rory?
Thanks, John. Good morning, everybody. I'm going to give an update on 5 pharmacy-related items. The expansion of the preferred drug list, redoing the reimbursement rates with the retail pharmacy network, a look at antipsychotic use in children, a new item, hemophilia drugs, and ways to improve quality and decrease waste with those, and a quick update on vaccinations that we started talking about in October. And note at the bottom of this slide, as John said, hats off to the department. DHS has begun some of these initiatives, had some momentum before. In some cases, we've improved their urgency to start, and we're going to report on that progress. So first, with respect to expanding the preferred drug list, recall that we took in our analysis, we looked at the percent of Medicaid pharmacy claims that were covered with those supplemental rebate contracts, and 38% of Medicaid claims, pharmacy claims, were covered by existing supplemental rebate contracts. We recommended that coverage of claims could be expanded possibly into the mid-60%. And right now, the department is targeting initiatives that could bring the coverage from 38% into the 50 to 60% coverage range. The value of expanding that coverage on an annual basis is projected at between $9 and $10 million in additional supplemental rebates. Timing of these initiatives, you see some of them are immediately timely. The department is evaluating several multi-state pools where multiple Medicaid states pool their lives together for additional drug negotiation rebate leverage with pharmaceutical companies. There are multiple multi-state pools available, so they're looking at a variety of those to see what's the best fit in terms of not just rebate yield, but programmatic fit and operational fit. They've been running a program by themselves with their own rebate contracts for several years, and through that have developed utilization criteria which fit their current contracts. When you fit their utilization criteria into the multi-state pool contracts, one side or the other might have to give, so they're evaluating the strategic fit as well as the rebate yield. That actual analysis should be done by the end of this month. Then there'll be a requirement for a state plan amendment to be submitted to CMS in the April timeframe of this year, which, if approved, and no reason it should not be approved because multi-state rebate pooling is an accepted criteria to allow all states. So no reason to believe it will not be approved. Could see implementation of that near the end of this year.
So, John, I see you back there. Do you agree that we are on track to have this program implemented by the end of 16?
Mr. Chairman, I'm going to have to defer to somebody from Medicaid who has more detail. I don't know.
I see
I'm
you
getting
shaking back there. Hopefully you.
I'm getting a yes.
Yeah. And do you also agree that it's likely to save $9 to $10 million a year? You do? Okay, thanks.
Next item is the reevaluating the reimbursement formulas with the retail pharmacy network. In our estimates from earlier reports, we thought it could save annual amounts up to around $18.3 million, depending on how aggressive the reimbursement changes were. Timing updates here, there's a mandatory CMS dispensing fee survey that's required, and that is near completion. Results should be available again at the end of this month. The department is going to look at potentially changing the benchmark that they pay pharmacies off from the benchmark that says how much should be reimbursed to the pharmacy for the ingredient cost for the Lipitor, not the dispensing fee survey, but how much do you pay for the drugs and what formulas to use to calculate those reimbursements. There's a national benchmark that tries to estimate acquisition costs, the NADAC. So they'll be doing a comparison of NADAC versus other potential benchmarks. Once that is decided in about the March timeframe, that also will be submitted to CMS in the plan amendment, and we expect approval of that.
Okay, so same question for our department folks. We are on track to submit this plan in April of this year. And we also agree that potential savings of $18 million annually. I mean, why don't you come on down and since we're asking about your program.
And Mr. Chairman, it's up to 18 million, so depending on how aggressive it is to be us.
We got another chair around there.
I'm Jason McDonald, on the pharmacy program. Yeah, we agree we're on track for the Mississippi survey and NADAC analysis, but we haven't got the NADAC analysis back yet to actually come up with a dollar figure as far as estimated savings.
Well, that will give us the ability to nail that down a little closer. Okay, can we just have a report on both of these as we move through those? Because between the two, you're looking at some fairly significant program changes with significant savings, and I think it'd be good for us to keep tabs on how that's going.
Absolutely.
Okay, thank you.
Next review is on use of antipsychotics, approval for use of antipsychotics in children. Today in the state, children 6 years old will undergo through a very rigorous medical review before they're allowed to be put on powerful antipsychotic drugs, and that is whether or not they're in foster care or not. Over the years since this program has begun, there's been a dramatic decrease in the use of antipsychotics in children 6 and under. So the reviews done by the department are way more than cost effective, they're cost positive, and in our opinion, definitely improve quality. So one of the things we had suggested early on last year was, boy, if the program works so well for 6 and under, why don't we consider expanding the age coverage? The department's moving in that direction. In fact, has resources and plans to begin reviews up to age 7 in next month, February 16. These are time-intensive reviews. There's a lot of children that need to be reviewed. So in a stepwise fashion, in April-ish of this year, could expand to include 8 and 9-year-olds. Then, in that same time frame, April of this year, Department expects to propose to review our board an expansion of beyond 9-year-olds, 10-year-olds, specifically 10-year-olds. If that's approved, then no reason to believe it wouldn't be, could begin implementing those reviews this summer. And again, I said there's a lot of cases to review. It's time intensive for the review. So sometime beginning in 2017, could imagine having up to.
Who is the DUR board that has to approve this stuff?
The RDO board of medical practice and physicians and pharmacists are in the state office.
So that's something we approved, we don't have any federal approval for? And you agree that like we're on track for like next year to have up to age 12?
We are on track.
And I guess with the cost, the question I have is, as you mentioned, I guess these reviews there's some cost involved in doing those reviews and time, but we have seen that they pay for themselves in the 6 and under population.
We have, in children less than 6 years of age, we decreased the non-foster by 95%.
By 95%?
The use of drugs.
In foster care, I think it's like 85%. So we do see a significant decrease, and those are reviewed by peer to peer, so that's.
So this is still just boggling my mind a little bit here. We reduced by 95% the use of antipsychotic drugs at 6 and under.
Yes. And this is based on safety only.
In your report, this month's report, there's a chart of those reductions between 2008 and last year.
Okay, thank you. We got a couple questions here. Representative Ferrari, right there.
Mr. Chair, our policy is not, who does the reviews?
The reviews are done two ways. We have actually a step approach on it. We do require informed consent and metabolic monitoring on all children less than 18 years of age. On children less than 6, these are reviewed by pediatric psychiatrists, part-time pediatric psychiatrists with my condition.
So it's not a department. Not a department of DHS or Medicaid.
It's actually,
independently done out.
it's outsourced as a contract, but they work within our department.
And we'll have to increase the contract to go up to 17 or 10.
To go up to 10, yes. Go up to 7, no. We're actually absorbing that within the contract we have right now. But to go up to the next level, it will require another part-time.
So what I just heard, you say 95% of that will pay for itself.
It does pay for itself when you look at average cost and psychotics are over $300.
Senator Sanders, you're right now. Thank you, Chair. One thing, and she's not here, she no longer works for the department. I know this was a project, and something that Jenny Huddleston cared very much about, in reducing the level of psychotropic drugs that we're using, antipsychotic drugs that we're using for our kids. So and I just, for a minute, obviously want to consider the financial side of this, but think about going to the human side of kids who are no longer on those drugs. And the basic question, restate this if I'm incorrect, is not adding a new program. This was just for safety concerns, is that correct? So if you could sort of discuss how we got to that 95% reduction and what was being applied and what was actually happening there.
Okay, and I believe, I don't have numbers in front of me, I think in 2008 we started the program in antipsychotics where we actually put dose edits on those for children. We set it up where, and I think it's 2010, 2011, we started with the pediatric psychiatrist bringing them on board to do reviews for less than 6. So it's a step process where we implement, the dose edits, the metabolic monitoring that we require informed consent by the parent or guardian, and then the reviews by pediatric psychiatrist. So it's several steps, and it's gone over since 2008. We've gone slowly in this process. We want to do the best for the children of the state, but in addition to, we want to do best for the state as a whole.
Yeah, and if we would too, obviously we're moving the thresholds up in terms of, have we seen sort of a sentinel effect in terms of causing reductions in other age populations that aren't currently undergoing review, or are we still looking at significant overuse of these drugs in these populations that have not been involved in the screening process?
We've seen a decrease just by our edits alone as far as the chronic limits and the home percent and the metabolic monitoring, but not to the previous, which we see the 95% decrease. I think in the next age population we look at, we're noticing a 45 to 50% decrease just with the edits alone. But then when you add on as far as the main review process, peer-to-peer review, that's what we'll see the decrease.
So we're essentially talking about incorrect parameters for prescribing these drugs today, or where it's not the best treatment protocol for the child is dealing with.
You see overutilization. I hate to say incorrect or inappropriate, but it's overutilization.
Go ahead.
And one other thing to think about in your evaluating the ability for the department to be effective in this is as kids get older, there are more reasonable uses for the drug. So there are more reasonable uses for a 10-year-old than a 6-year-old. There are more reasonable uses for a 12 or 15-year-old than for a 6-year-old. So the impact of the older age cohorts will be less. It's still significant.
Thanks. Senator Elliott, you recognize.
Thank you, Mr. Chair. As funny as the 95% number is, I'm really glad to hear it, actually. I just want to get a clarification about the DOR board. Is this a group that will have a proposals made to them? Will they have the final say of what happens? What authority do they actually have?
RDR Board is a recommendation board, so
Okay.
we present proposals to the RDR Board and they vote as a recommendation for changes in the department or the farm program.
So historically speaking, do you generally follow their recommendations?
We generally follow the recommendations. If there's, we prefer a unanimous vote. If there's any controversy in our board, we have to pass full recommendations to go back and rework to get to the best solution for the state.
What do you mean a better solution for the state? Are you talking dollars or care?
Care.
Okay, all right, thank you. That is it.
No other questions? Continue with the last two updates. First one is improving quality and decreasing waste in hemophilia factor drugs. So used a lot in children with bleeding disorders on an emergency basis and a maintenance basis. These drugs are extremely expensive. And today, they're allowed to be dispensed by most any pharmacy who wants to invest in the inventory and fill prescriptions. In the future, the department is going to implement some quality criteria that will eliminate some pharmacies from participating. Specifically, the quality initiatives they're going to have to meet are around helping patients and families manage waste of the products, because it's so expensive that pharmacies who have a broader inventory and more experience in treating these kind of patients can actually manage the patient through dispensing more appropriate doses, more appropriate vial sizes for the child's treatment. And we don't have a number today. We're trying to get a impact number of this for February, but it's very convoluted analysis. It isn't just a simple child got X yesterday, gets Y tomorrow, and the difference is savings. We're going to have to see if there's a way to get you a proxy for the value of this decreased waste. And we're working on that. And final update on vaccinations. One piece of good news, one continued bad. In last year's flu season, state of Arkansas hit the national goal of having at least 50% of people over 6 months old in the state vaccinated for influenza. That was awesome. But in childhood vaccines, the typical childhood trio of measles, mumps, rubella, the Tdap and chickenpox vaccines, Arkansas and Colorado both scored below 89% of children receiving those vaccinations. And this scorecard isn't specific to Medicaid. This is for all children in the state. We had made some recommendations around ways to improve that. And those are already on the record, but we are going to do some further analysis into the split between how many vaccinations both childhood and adult are given by public health versus how many are given by providers in the state. So we're going to see if we can get some kind of additional insight into how changes in reimbursement might affect the vaccination rates. And best hope is we have some info on that for February.
Thank you, Rory.
I just want to say thanks to the Department of Pharmacy folks for working to get this stuff going instead of waiting until the end of the process. It's great work.
And I will echo that, Mr. Chairman, and I want you all to know in our savings estimates, we'll do the best for those numbers. So it won't be just the entity or the management fee service structure, it's going to be all these other things that are going on too. Dental claims history, I just wanted to make sure, I know that, we worked at the last meeting on the decision on the managed care alternative for dental, and I want you to know a little about the history real briefly. And because this is going to be important when the governor mentioned a certain amount of savings to be attributed to the dental program based on managed care, and he had been provided a number. We're going to be verifying that number and looking at other states as well. And the number that the governor provided does not seem to be unreasonable if you look at the total amount of claims. And you can see that the claims from 2010 to 15 have gone up. These are mostly your dental services for your children population. You have some adult, very limited in your Medicaid program. But you can see where there's a number of, where the increase are, and I think the next slide, you can see about a 4.6% increase over that time period. But something, question should be had, and we just haven't had time to really dig into what has been going on in the last few years, or last year, the 8.1% increase. But again, very manageable program for these companies to handle. The recipients have been increasing. There was a small reduction there, you can see, from 2012-13. I'm not sure why, but again, when you look at dental, you want to look at two things: access and preventative services. Those are the two areas that most Medicaid programs are trying to really promote, and that's something in your RFP you'll want to make sure you put some type of incentives around. So you can see the growth rate here in recipients.
Okay, we got a question real quick. Representative Ferguson, you're recognized.
I just had a question. Does this growth increase, is it a reflection of the ACA requirement for pediatric dental?
It could be, and I haven't been able to ask those types of questions yet. I can if you like.
Okay.
Or the department maybe will address it here, but we'll come back and address that for you. But I want to kind of set up the discussion for the managed care dental issue that you all have looked at. We looked at these other states in your task force report, in the status report, the actual written report. We actually have listed all the states and the different models, and it's a very comprehensive list of every state. The managed care would be the administration of all Medicaid dental benefits on a full risk capitated basis. In this case, the state would compensate the managed care company using actuarial sound rates. It's no different than the traditional Medicaid non-dental area if you were to move in managed care. CMS will require at least two companies based upon the waiver requirements. Providers will be compensated on a fee-for-service basis. And that will be the company, the managed care company, that will be doing the compensating or paying the claims. The RFP should include, I mentioned, incentives for benchmark cost savings. Some of the RFPs out there have not addressed this issue. And the reason I say that is go back to, you come up with a certain amount of savings that you want to have met in the system. And you say, we believe that these savings can be met. And in the contract, you have the ability to put in the RFP certain performance measures so that those savings are actually met. Obviously, if the number of recipients goes up and there are other triggers that you can't control, that's another issue. But that's something that you're going to want to make sure that the department not just talks about access, increasing access, not just talking about prevention programs, but if you want to meet the savings, I think you're going to have to make sure the benchmark goes in the contract.
Can I just ask a question about, again, how I'm still trying to grasp this managed care, how it all works out here, but because on the first point there, you say it's a per member per month rate. State pays to the managed care organization. And then you say in the third bullet, providers will be compensated on a fee for service. I assume that's coming from the managed care organization?
Correct.
So the state then really has no fee for service for that type, it all goes just on the per member per month to the managed care organization?
Correct. And in some states, they've actually retained a certain small part of the population that have outsourced to dental managed care. And that becomes problematic. So we're going to have to hear from the department what their plan is, because you have an MMIS claims system. I know that the department has been spending millions of dollars going forward on changing and transferring their system to have an upgraded medical dental claims system. Well, the managed care companies also do dental claims. And so you want to reduce any redundancy or duplication, but you can't tell the department, stop spending the money and moving in that direction today, because they aren't at that level of managed care yet. The claims aren't being paid. But at some point, and I have one of my staff members who's going to be looking at this for you, at some point we want to make sure that MMIS spending takes into account when this goes live, the reduction in the MMIS side. And that goes back to Senator Distide's issue about the 90-10. You're actually spending a lot less state dollars, but you don't want to spend money where you don't have to. That's an issue. And the reason I raise that is if they retain some portion of the population in dental that's not in the managed care program, then you're gonna still need the state Medicaid claim system, and you're gonna have to be paying for two systems. We have not been able to talk to the department yet about their plans, because they're focused on coming back in February before you with the overall model. But this will give you a perspective for what managed care is about, and I think it's important for you to hear from the department what their plans are, and we'll work with them on how they're gonna be handling this issue.
Representative Ferguson's got a question you recognize.
You brought up a point that I had asked Medicaid exactly that. It's my understanding, and maybe someone from Medicaid can explain, that HP won't even be ready to handle the new claims management for dental until 2017, which we would actually be turning dental over to a managed care company if we proceed with RFP as suggested. I had asked them about discontinuing that NMIS for dental with HP going forward. So, I mean, is that something we could ask him to look into?
It's okay with you. I mean, I would just say that I think that's really important. It's part of our looking at the February model anyways, because we want to make sure any contracted savings we can accept going forward in 17 and 18. So we're looking at that, but we'll specifically, if you would like, address that issue at the next meeting.
Right. I mean, I'm like you, I don't see the necessity of continuing it with Medicaid with HP if we're going to be moving this claims management to a managed care company. It's unfortunate that we weren't able to get that online already, because that's been the dentist's biggest concern with the way Medicaid handles claims, is the claims management aspect and prioritizations. But I don't know what, I couldn't get an answer as they couldn't break out that portion of what the dental MMIS was costing with HP. They couldn't break it out of the total package cost. So I'd be curious to know what the dental part is costing, because I don't really see the necessity of continuing that part of the contract if we're going to move to managed care.
We'll have a report for you at the next meeting. So the shared savings, the same issues of quality too on prevention and services. I think it's important, the prevention services on the front are going to help. But I'll tell you one thing, in that the task force should be mindful when you get a report from the department. There's one area in Medicaid dental that is across the nation, and it was an issue when I was a secretary, it really bothered me. A lot of the children don't show up at their appointments. And I think we have over 45 to 50% of the children in Medicaid were not showing up at their dental appointments. And then I had another analysis done that showed about 20 days per year they're missing out of school because of dental issues. And then you start looking at the long-term effects there. What I would do is make sure that RFP has some incentives built in that requires that those individuals, that the children get to their dental appointments, and if the company that you're outsourcing to is managing the program, that make it their responsibility to do everything they can to help make sure that those appointments are met. It's just one issue you might want to look at. But again, they're just issues that go into the contracting side. So this is what, the next slide shows you what the RFP should include for the medical home for all enrollees. And again, this is consistent with what a managed care RFP would be for your traditional Medicaid program. You're going to have claims payment, credentialing, utilization management, this is the whole gambit. But now, what's going to really be important here is, maybe the credentialing will still be done by a provider if you don't go to full managed care for the other programs. And there's going to be some risk of duplication and risk of creating less value for the taxpayer in the long run. So you have to really be careful here that you're not also spending dollars on the credentialing side on the normal program, and you're not getting the reduced amount that you're going to now for the outsourcing. So it may sound a little complex right now, but we've got to figure out a way to make sure that there's going to be reductions then on one side, increases on the other side.
What's the common practice of the 28 states or however they've gone to managed care with regard to dental?
That's all in that's in your status report. And I can tell you, just looking at it, most of the states are moving into full capitated managed care for dental.
Are they carving it out?
Most of them keep it within the managed care plans, and the managed care plan will either do it themselves, or most of them subcontract with the same companies that actually would probably be bidding on doing it here alone.
Gotcha.
And any questions, these are the key areas I think you're gonna wanna make sure we keep track of. The next area is the integrated systems, and this was Senator Hendren's question. And maybe this will help the department going forward, because we did a very thorough review of states that are now looking, that have integrated systems. Senator Hendren wanted to know what are some of the best practices out there. There's more detail in the status report. I'll go over a few of the states in the slides here. There are states out there that have really done a superb job that we have found in integrating HHS systems. I wish Senator Urban was here because this is a big issue she keeps raising. And at the end of the day, you know, you don't have an integrated service here with your own EDF and TANF alone in your workforce. And the governor wants you to move forward on work requirements, and you got to come to that area at some point in your eligibility system. So the states we're going to go through in some of the systems have already taken advantage of that 90/10 federal funding, and they're starting to put together all their human service systems. The systems look at pre-screening, single application for customized benefits. That was a goal. I remember in Mississippi a few years, that was one of the goals of the Department of Human Services Directive. Incorporate real-time decisions, member portals to view application status, business rules engines and incorporate rules across multiple programs, integrated call centers, electronic data matching, enhanced document imaging. Again, a lot of the states that we looked at are way beyond where we've seen here, but it is costly to get there. So this is not without cost. Data management analytics, merging data from multiple sources. There's mobile apps for dynamic provider directory, real-time digital medical ID cards. Some really good things happening across the country. North Carolina is probably the best state we looked at in terms of integrated systems. Interestingly, I believe North Carolina is a Cure product. 17 DHS programs, including child care, food, nutrition, TANF, Medicaid, workforce, energy assistance. Additional successful implementation of integrated SNAP and TANF. Programs in child services, aging and adult. Includes case management. The state has access to comprehensive current data integrated across systems of accountability and decision making. So it means dashboards. The directors can use information coming out of the eligibility system. It's very usable for managers. It incorporates fraud detection software, flags suspicious billing. And all this, there's citations in our report on the people we spoke to and some of the state leaders that the DHS can reach out to as well as they go through their own review of upgrades and making sure the EDS system meets your goals. New Mexico has an integrated system on SNAP, TANF, and cash assistance, refugee gas, energy assistance, basically integrated in determining eligibility. And that was the whole vision of that whole 90/10 funding that came out of the federal government. This includes modules for all agency business rules. A self-service website allows initial application and access to case information, as well as recertification, case changes. That's all in New Mexico.
Okay, we've got a question here, Representative Cirillo, and then we're going to go to about 11:45, and then we'll stop for lunch till 1, so, or a convenient place there. But anyway, Representative Cirillo, you recognize for a question.
Thank you, Mr. Chair. John, I guess my question is, when I look at this across the board, what is being done with the integration, the question I have is why don't we here in Arkansas have that same integration, because we actually are running Current. The only thing is, Mr. Myers said the other day, is that they're using Magi. So if you look at SNAP and traditional Medicare, Magi and those things, we should have the capability, if this is working elsewhere, and certainly that would be the model. I have a conflicting position in regards to how effective this program using, and I'm not citing Current because this is a very difficult task. But that is what we're using, and if I'm correct, we renew it each year. I think at about $6 million, we bought the mainframe, and we're using that. So why aren't we looking at these other programs and merging them in? That would be my question.
Well, I think it's a really good question, and you'll have to ask the department, because I think that the Gardner report that the governor had commissioned, I put in your packet, that has the current phases, the 7 different factors and where they are, and they're having a kickoff meeting, by the way, tomorrow with the department. So there's been a long history of the DEF system here, as you all know. But I think that a systems integrator is going to put you in a much better situation. We agreed with that in our recommendations. This integration is not, it's not easy, but it has happened, and it can happen, and can benefit your state in the long run. And I know the department is looking long-term at that vision. How they're going to get there, they're going to have to explain to you, and you're going to have to monitor that closely to make sure, and that's what I think Representative Collins wanted us to stay closely in touch with Gardner. In our next month meeting, we're going to have a report for you, what that kickoff meeting was about yesterday, how they're making progress, where they're going, and what their longer-term and short-term objectives are. So we're in a much better situation for you in February. But what I'm showing you here is there are states that have absolutely been able to get over those hurdles. And it could have been because they had the right systems integration, the right planning ahead of time. You can get there.
Well, I guess my question to you is, I understand you can get there. I've been told that it costs $500 million in North Carolina to engage with the particular current program. And so we've already spent about $106 million in a system that has not been functional. We're using existing systems right now, which doesn't include the Current outside the Magi. So the question is, there could be a major change in November 2016, and all these programs could be changed. And looking at it, probably cost us $200 million to add the SNAP and the traditional Medicare and into that right now. And so, you look at $100 million already invested just to cover those 3 programs, another $200 million. I mean, we're talking about a lot of money. And if we're talking about savings, my opinion would be we got to look at all aspects of it. And the question is, right now we've got a system working. It's not, it's probably not the best, but are we going to roll dice and spend millions of dollars until these programs are proven, or these systems are proven? I think that's my question. How can you forecast that in the future in regards to our cost and our investment and what works?
Well, I'm not in a position to answer that question. Martha from my team did look at the most current update for you is in the status report. She did look at the criteria, and it's very detailed. She can't be here today, but it's very detailed in terms of what she believes the next steps are that are needed. And I think the big issue for us is going to be what happens in that kickoff meeting, how the department and Gardner begin to work together. They have to then put an RFP out. They have to meet certain factors that the Gardner report had, which we agree with, had identified. And I want to be able to come back to you in the next meeting and say, we feel comfortable they're heading in the right direction. Yes, it's going to be costly. There's no question. Every state has spent a lot of mostly federal dollars on integration here. And the phases are such that when the first pot of money came out of Magi after the Affordable Care Act, it was all about getting the Magi system up and running, getting your state integrated with that system, with basically the determination. But then the states that had the foresight to pre-plan with the advanced planning documents that are doing well said at the beginning, we don't only want Magi, we want TANF, we want SNAP, we want all these other human service systems. And they put that in their advanced planning document, and they began to chart their plan, their roadmap, in the very beginning. And there was a systems integrator that made sure every step of the way they were at least trying to meet it. If there was fallback, they would fix it. But the states that have failed didn't have that type of project management approach. And that's what we're seeing here.
Okay, we've got, are you got more? Push your button again, and We're going to take a break right after this question, so go ahead, push your button. Okay.
John, who owns the government report? In essence, what was it, about a $500,000 report, somewhere in that vicinity? Do you know? The question, I guess when I say who owns it, in regards to, someone needs to be responsible. Did the legislative body, are we the ones that funded that? Do you know?
The Gardner report, I'm not sure, you'd have to ask them, it was from the governor's office, I don't know where the money came.
Okay, so you really don't have too much background on the Gardner report?
Martha, we've actually reviewed it thoroughly, and I trust her judgment, and she's issued a report and recommendation. Very consistent with Gardner. She felt that Gardner may have not gone as far as it could have gone in terms of his recommendations. I think she mentioned at the last meeting, but felt that those 7 criteria were a good thing and supported the governor in what he had asked for.
Okay, I guess my question is, when I say who owns it, now that we've spent that money, someone needs to be responsible for it.
Yes.
And that we're implementing those recommendations. Do you know who that person would be or what?
I mean, Director Sealy would have to be asked that question. I know he's really stayed on top of the issue from day one.
Mr. Chairman, that's us and DIS working together with the governor's office. All three are driving that.
But there's not one entity that's responsible for the...
Well, DIS commissioned the report, so I would say they have the overall lead on it.
Okay, thank you.
Okay, we've got Representative Hammer and Senator Sanders on the list. I'm going to ask, would you guys mind holding your questions till after lunch? Would that be okay? Because we've got more. This is a pretty lengthy topic that we're in the middle of, and I want to make sure we don't cut it short. So let's go ahead and plan on breaking for lunch. We'll come back at 1 p.m. Let me just, for the benefit of the members, the governor did confirm that he would be with us on the 17th with his report from DC.
We got somewhere where you're going to say like, this year is this number.
Well, we've actually got until about,
So basically, it's been around 3% in 2012. They were
that would be considered
No, that makes sense. That makes sense. And like, saying this is on this so this is basically saving up.
yeah, it's just instead of 5%.
But